All right, so we did have a couple more people join, so I think this is a good time as any to get started. First, I'm going to say welcome to everybody. My name is Chelsea Fix. My title at NephCure is Manager of Research Engagement. And we're going to get started with our Demystifying Research webinar. So first, what I want to do, I want to remind everybody why we are all here tonight. And that is because, let's face it, there are really no great treatment options for primary nephrotic syndrome and the related diseases, FSGS, minimal change, IgA. And that's just not great. That honestly, it kind of sucks, for lack of a better word. So what is the solution? The solution is research. And research is a necessity to us to get any better treatment option to your drugstore shelf. And remember, the most important points here under our solution, I just want to point out this first one, that any drug or treatment that you have ever taken ever in your life has been through the research process. And that research process includes patient volunteers that were involved in that. So let's just keep that in mind while we go through this webinar. And before we really get started, just some housekeeping things. Right now, I do have everybody muted, and that is just to reduce the background noise going on. So if you have any questions, on the right-hand side, you should have your panel, and there is a question box. So if you have a question come up during the presentation, feel free to go ahead and type that in. And at the end, we're going to address all the questions, and at that point, I will unmute everybody, and we can have a little more informal session. The last thing I want to mention is that we are going to record this session, so if you want to keep your privacy, your name private, that's fine. Just don't feel pressured to introduce yourself. Just be mindful that this is being recorded. And with that, I want to introduce our guest panelist, Dr. Jonathan Hogan, who is going to walk us through our presentation tonight. John? John, I can't hear you. I don't know if you're talking. Let me see. Okay, I'm going to see if John's having some technical difficulties. If not, we can get started until he maybe figures those out. It's inevitable with these kind of systems that this always happens. John, do you hear me?
Yes.
Okay, there we go. I hear you now.
Okay, good.
All right, sorry about that, everybody.
That's okay.
Like I said, it's inevitable that something like this always happens. Okay, so why don't we start with the first slide. John, do you want to introduce yourself or anything?
Sure. Can you hear me okay now?
Yes, perfect.
Okay, great. Great. So my name is Jonathan Hogan. I'm at the University of Pennsylvania in Philadelphia, Pennsylvania, and I specialize in patients with nephrotic syndrome and glomerular disease, and it's a real honor to be here tonight to be connecting through the NephCure Kidney International with patients who are interested in nephrotic syndrome research and to try to push our field forward. So thank you for this opportunity. The first slide that I'm going to go over in the first few slides actually is to go over a few of the basic types of research so that people are on the same page about what types of research are out there in all medical fields. And the first type of research is basic science. What basic science tries to answer are really a few of the following questions, such as what is the underlying mechanism of disease? So when we talk about the nephrotic syndrome, as it says, is a syndrome. It doesn't tell you actually what causes it. So we need things like basic science to try to inform us as to what is actually going on that's causing the protein in the urine, the swelling in the body, and all the other problems that come with the nephrotic syndrome. It also tries to target, well, would a certain drug work on that mechanism? And are there any genes that are involved in contributing to that disease? Are there other molecules in the body that are involved? So are there other systems or other circulating molecules, proteins in the body that are causing the problem? How much does environment affect the disease? So I'm sure many of you have the personal experience or have heard that there's certain triggers or things that make a certain cause of the nephrotic syndrome happen, and we're trying to figure that out as well. What molecules in the body do certain drugs affect, and other aspects of basic science of the disease, which, some people devote their entire lives, get multiple degrees and spend their entire lives in the lab thinking about different approaches to these diseases. So this is a very, very important part of research in the nephrotic syndrome. Next slide. So getting out of the lab and into actual clinical practice is what's called translational research. Now, translational research is a very attractive topic because, the idea is that somebody, comes to some sort of conclusion in the lab and uses that knowledge and applies it directly to patient care. And that's a very, very important part of what's going on in nephrotic syndrome research these days and all throughout medicine. But it's sort of easier said than done. And we'll get into that in a little bit. And some of the questions that translational research answers or tries to answer are, why do certain medicines that are off-label, which means that they're not technically approved to be used for that condition, why do they work in some patients and for some other diseases? And why didn't it work in all patients? How does this finding in the lab help the patient community? So can this be applied to actually help patients? And how do we explain what's happening in the patient community in the lab? And so we basically take findings from the lab, go to the patients, and we try to study these findings in patients and take what we find and bring that back to the lab. So it's sort of this reciprocal relationship between the lab, the clinicians, and the patients. And the findings from the lab are used in a way that is useful to the patient community and really tries to take that to the broader community eventually through clinical research, which I'll talk about in a second. And again, the sort of, catchphrase for translational research is bench to bedside. So you may hear that in various conversations about translational research. Next slide, please. And the third type of research is clinical research. And clinical research really tries to answer a few questions such as, does a certain medicine work in the way that we would expect it to work? And what type of side effects are there? And is one medicine more effective than another medicine or what's currently available for that condition? It also uses statistics and what's called epidemiology, which is trying to look at large groups of patients to try to identify diseases and trends to figure out, well, how common is this disease in a given city, state, in a given racial population, in men versus women? And sort of how do those patients act over time? How does the disease present? How do patients come down with the disease? What happens to them as they go through, the next few months and years with this disease? And what symptoms are common and uncommon with disease? And this sort of helps us to try to better define and characterize these diseases. And again, if you are familiar with nephrotic syndrome and the causes of it, it's very frustrating to have conversations with patients about FSGS and minimal chain disease. And I'm sure it's equally as frustrating, if not more so, to hear this from your doctors and to read about it, that these are not really descriptors of what's going on in the disease, but rather, what the biopsy looks under the microscope. So clinical research tries to move that forward into the patient arena and really figure out how the disease affects patients. Next slide, please. In terms of clinical research, there's a few different important components of clinical research which are important to highlight. And really, the first one is that the necessary component is that we need human volunteers, human patients who have the condition in order to study. And without that, clinical research will not go anywhere. And we'll get more into how we can help to promote moving that forward a little bit later. Two types of studies are either observational, where we just watch patients over time and see what happens to them and collect data from them and maybe collect blood samples and urine samples depending on the study, or interventional studies where we actually give a patient a medicine and see how it affects the patient. But there are certain components of every study, and those include what are called inclusion and exclusion criteria. So those are things that will either make the patient eligible or ineligible to participate in a study. For example, if you have a cause of the nephrotic syndrome that has eventually led to the patient being on dialysis, and you want to try to use a new therapy, then a patient who's on dialysis may not be the best person to try for that study because they may not show any benefit. For example, you cannot measure the protein amount in the urine, and the kidneys are already scarred and are not able to function anymore, and so we may not want to include those patients. Whereas for other studies, a patient on dialysis may be the person that you would like to try. So there are certain criteria and certain characteristics that are looked for in patients to enter into a study. They always have to have informed consent, so a patient needs to understand the study and what's entailed in the study and what are the risks and benefits of the study, and that must be provided in writing. There's always an investigator or PI, which is short for principal investigator at a certain site where the study is going on, and the study coordinator, and those people are the most important people for the study at that site. There's the Institutional Review Board, which is also known as the IRB, which is made up of doctors, nurses, other healthcare providers, as well as people who are experts in ethics, as well as patient advocates who try to make sure that what's proposed in the study is in the best interest of the patient, that there is no conflict of interest, so that somebody has another agenda that is trying to be promoted. This is required at all institutions conducting research. And then there's the recruiting site. So there are certain sites that participate in certain research studies and others that do not. And so as you're thinking about if you're interested in participating in any studies, just because your center or your doctor's office does not mean that there's not another center close by that may be recruiting for a study that may be of interest to you. Moving on to the bottom of the slide, there are different study phases. So phase one, where you'll hear a phase one clinical trial, involves a small group of patient volunteers, which is really trying to figure out if the drug that they're going to test is safe, tolerable, and which doses we should be thinking about trying. And when I get to the bottom of the slide, I should have said that this is when you think about a randomized trial or a controlled trial where a new drug is being introduced. And we'll get to that in a second. Phase two, we take a larger group of volunteers and try different doses and try to see if there's any effect on the condition. Because when you start out, you don't know what dose would work best. Is it 1 milligram, 2 milligrams, 10 milligrams? We can only find that out through things like a phase two trial. And phase three trials are the largest group of patients. And generally speaking, this tries to compare one drug or one therapy with another treatment option, which may be another new treatment option or the current standard of care option, the current standard option available to patients. And that's sort of where everybody tries to get to, because what's required in order for a drug to become approved is that it's shown to be better or at least as good as what's currently available. Next slide, please. So the reality of nephrotic syndrome and really kidney disease research in general is that there are many types of research that are currently happening. There are a few long-term observational studies, which I'll mention in the next slide. There are clinical drug trials, which we'll also mention in following slides, and there is genetic research. But there needs to be more research, and we're going to talk about how we can help to promote nephrotic syndrome and kidney disease research in just a few slides. But what's also important to understand is that there's a competition for resources. These studies are extremely expensive to run, and one could talk for hours and hours about why that is. But there's a competition for resources that, the funds, the money that is available to pay for these studies is also in competition with the types of studies that you see on the news about cancer research or Alzheimer's disease research. So there really is a competition to try to get the resources to fund these type of studies, and we'll talk about that again. But that funding is finite and limited, and so if there is frustration about what's going on with certain type of research in a certain field, that is part of the situation of raising the awareness, raising the profile, and trying to figure out ways to get funding and resources for new studies. But the most important resource is the patients, and particularly in the day and age of using the internet and social media, there's a real ability to empower the patient population with the disease to help to move that forward. But that competition for resources can slow the whole research process, which is why all medical discoveries take a long time. And many of the mainstream newsworthy breakthroughs are very hard to come by. So many of the types of breakthroughs that you hear about on the nightly news, first of all, many of those will never come to fruition in terms of actually meaning anything for a patient. They just are very high profile. The ones that often are very, very important take a long, long time at a very slow pace, but eventually we get to the goal. So this is a marathon and not a sprint. And so I think that's what we're trying to encourage patients to understand and to get involved in it to help us to complete that marathon together. And finally, you know, one challenge of kidney disease research in general is that the only endpoint that is recognized by the FDA, by the government, as a clinically important endpoint for kidney disease is really renal function or kidney function. And that's different than other types of diseases. So other types of diseases can measure, you know, the number of heart attacks that somebody has in 1 year or the number of hospitalizations. But in our field, we are bound to study kidney function. And the kidney is affected so harshly by many of these conditions that there's oftentimes very irreversible injury. So finding a really significant, and I'll talk about what that means in a few slides, a significant difference in kidney function between treatments is very, very challenging. Next slide, please. Some of the other struggles for nephrotic syndrome research, besides competing for these resources, are, you know, the trial design, which may not be best for all patients in a given disease group. The site selection has to be right to try to find the right patient. So if you're doing a trial that has, you know, a certain type of patient that you're looking for, but those patients do not live in that area, it can be very difficult, especially for rare diseases where a center that's not close to your home may be running a trial, but you may not be near there. Recruiting patients can be very difficult, especially for rare diseases. Trying to identify the patients that meet the criteria and then get them to take off of work and come in is not the easiest thing. As I mentioned before, the kidney function endpoints can be very challenging to try to meet. And finally, there's another aspect which I'll touch on briefly, which is this idea of a silo. And the idea of a silo or research silos is that people who are trying to do research in these fields oftentimes have to protect themselves by keeping information to themselves, because if somebody else gets it, it's a very competitive situation. So people tend to try to do things alone. In some ways it's cultural, in other ways it's trying to protect what they're trying to build for patient care. But as you can imagine, if people are trying to protect themselves and protect certain information, this means less collaboration. And so a lot of those barriers are being broken down, as I'll talk about soon. Next slide, please. But there are a lot of really exciting recent clinical breakthroughs and basic and translational research breakthroughs in nephrotic syndrome and in kidney disease. So under the clinical arena, the National Institutes of Health, which is the main government agency that funds research in the United States, has funded 2 large observational studies, which are called CureGN and NephCure. And I'll talk about those in a minute. But these are very important, where the largest study for patients, for example, with FSGS ever published is, you know, you're talking about, 1 or 200 patients. This study is trying to recruit 600 patients with FSGS, that is CureGN, trying to recruit 600 patients with FSGS, a total of 2,400 patients with multiple different causes of nephrotic syndrome to follow them over time. So these are observational studies. And then there's been a lot of new data on new agents in nephrotic syndrome and kidney disease. Whereas if you looked in the literature about 15 years ago, all you saw was the same thing, steroids, Cytoxan. But now we've had multiple new agents tried in the last 10, 15 years, trying to get better outcomes with less side effects. And then in terms of basic and translational research, there have been a few huge discoveries, such as the discovery of what's called the PLA2R antibody. This is an antibody. Now, antibodies are usually used to fight infections, but in cases of other diseases, they actually can attack one's own body. And it's thought that this PLA2R is involved in the majority of cases of patients with membranous nephropathy. And as you can see at the bottom of the screen, this was published in the New England Journal of Medicine, and this is very high profile, and this is one of the few New England Journal of Medicine papers in our field. But this is a very encouraging sign that we're coming up with very important clinical discoveries that can be used to help patients. And then finally, the discovery of the ApoL1 gene, and this is going to be a massive discovery as well in terms of understanding why certain patients develop chronic kidney disease over time. Next slide, please. So just to reiterate what I said on the last slide, the long-term observational studies are the CURE-GN and NephCure studies. These are studies that are recruiting large numbers of patients to follow patients and collect data over time to better understand. So that, say, in 2-3 years, somebody comes up with an idea. Hey, is this PLA2R or is this other molecule involved in membranous nephropathy? Well, now instead of a handful of patients, you have 600 patients that you can test that theory in. And then we have clinical trials like the DUET study and a few of the others that are mentioned here that are actually trying to use new treatment approaches to see if we can help patients with the nephrotic syndrome. And as you can see, there's 19 clinical studies recruiting volunteers with about 290 sites across the United States. So if you were to put that map up, we're trying to collect as many patients as possible to help move this field forward. But most important in that is trying to connect clinicians and patients with each other, and things like the NephCure Kidney International Patient Network Registry is probably one of the most important things that can be used, the most important tool that can be used to help to accomplish this goal. And we're going to talk about that in the following few slides. Next slide, please. So the NephCure Kidney Network is a registry for patients with diseases that cause primary nephrotic syndrome, which really allows your voice to be heard in order to help advance research in this field to find better therapies and cures. And I cannot overstate how important this is. Again, if you look at any disease where real progress has been made, the patient advocacy and the mobilization of patients to work together to get better awareness of their disease and to work together to get more information to doctors and clinicians and researchers about their disease is the only thing that moves things forward. And with the internet, registries, and social media, we're at a time in history right now where we really can do that in a way that we've never been able to do that before. So I'm going to turn it over to Chelsea for a few slides to further discuss this.
Thank you, Dr. Hogan. That was such a nice introduction to the NephCure Kidney Network, our patient registry. I do just want to drive the point home that participating in research is obviously very important. And something that you can do right now to help move research forward, to help get those better drugs to the shelf, is participate, or as I like to call it, make a data donation in the NKN. And again, that is something impactful that you can do, as soon as we are done with this. And at the bottom of the slide here, you'll see the steps. The website is nephcurekidneynetwork.org, and you go in and you read the informed consent that goes over what the registry is, how your data is used, how your privacy is protected, and if you have any questions, I would be happy to answer them or talk to you about that. At that point, you'll create a logon, and then you will see a survey. It's a nice long survey getting all kinds of wonderful information. And this is really the best way for you to tell your story in a scientific way that gets the attention of researchers. So, I hear stories all the time about people who tell me that this has worked for them and this hasn't, and that's great. And the best thing that you can do to help everybody understand this disease and what you've gone through is to put that information in a little more scientific format, which is what the NephCure Kidney Network Patient Registry can help you do. Just a reminder, the survey is a little long, but you don't have to finish it all at once. You can save your work, take a break, come back later. And we do like to keep it as up to date as possible. So twice a year, we will email you and remind you to take a look at your records and see what has changed. Maybe medicines have changed, maybe how you feel has changed, and that will be reflected in your registry profile. So just to drive the point home, I just want to go over one more time some of the benefits of participating in the registry. Obviously, we are helping to increase research on nephrotic syndrome patients and their therapy. We can connect patients to the research that is being done and help match them to what is going on around them. You are a community. Dr. Hogan mentioned that all these success stories of rare diseases started with a mobilized and activated patient community where they were advocating for themselves. And the NephCure Kidney Network really allows you to do that. So if you have any questions about the NKN, I would be happy to help you. And again, the website is there at the bottom. It is nephcurekidneynetwork.org. So moving on, I do want to talk about what else is NephCure doing to help research efforts, because, besides the NKN, we care about nephrotic syndrome research from all angles. Our ultimate goal is to engage a broad community to leverage support that will get you better treatment options, get those better drugs to the shelf faster. So we work towards that goal by doing all of these things. We provide grants to both basic researchers that we talked about and clinical studies and the observational studies and things like that. We tell our patient community, we tell you about clinical trials that are going on, whether or not you are in the NephCure Kidney Network. The NephCure Kidney Network just allows us to help find ones that are more specified for you, okay? We advocate in DC for research funding. As we talked about, there's competition for those resources, and funding is definitely one of them. And finally, because we talked about the NephCure Kidney Network, I do want to mention our newest and probably one of our biggest initiatives, and that is the NephCure Accelerating Cures Institute. And we call it NACI. So what NACI, or the NephCure Accelerating Cures Institute, is meant to do, it is meant to be a system that helps ensure clinical trial success to help get those better treatment options faster. So a couple slides ago, we saw the struggles of nephrotic syndrome research, the poor trial design that people weren't eligible for, or how hard it was to find a good site. We are hoping that NACI can address some of those issues and make research go much smoother and cheaper and get it done faster so that we can get those better treatments for you. And if you're interested in learning more about NACI, I encourage you to visit the website nephcure.org, and we have information on NACI on there and information about all of our opportunities to help move research forward. And with that, I'm going to turn it back over to Dr. Hogan to talk about what you can do.
Great, thank you, Chelsea. So I think, the NephCure Kidney International Registry is a great example of patients taking control and raising awareness, for themselves and for, to make a community of patients. And there's obviously powers in numbers. And one example of how this has been successful in medical research is in things like cancer research. And I'm not sure how many people saw the recent PBS documentary on cancer and how research in cancer really moved forward, but it's a long story that involved a lot of people taking the long view and also realizing what needed to be done to make things move forward for research in the world and in this country. And it involved a lot of the things about lobbying Congress and getting your local and your national congressmen and women involved in being aware that these are diseases that are affecting their constituents and their people that live in their areas. And so cancer research and cystic fibrosis research are some really big time success stories that we're learning from in order to help move research in nephrotic syndrome and chronic kidney disease forward. But the vital ingredient to all of this research success is really an empowered patient community. So if the patient community is not advocating for itself and not coming together and using the tools like the NephCure Kidney International Patient Registry Network, then we're not going to be able to get as far as we should be. And really participating, talking to your doctors about clinical trials. As you can see, there's a few studies there that are listed, as well as a few of the ones that I mentioned before. And if you're not sure how to do that or how to start that process, and joining the NephCure Kidney Network can help you to connect to these clinical trials by making that data donation, and therefore you will be identified as a patient who can be notified, so that if you're interested in these trials, that you can contact somebody that's in a site that's near you. And the way I always tell patients is, you have to advocate for yourselves in terms of asking questions, looking around for other resources that may be available for you, and reading as many articles as you can without getting lost in all the jargon. And really when you bring an article to your doctor, it shows that you're invested in your disease process and in trying to move things forward for yourself and for your patient community. Next slide, please. So to summarize what we've discussed today, there are basic translational and clinical research that work together while also competing for the same resources to move nephrotic syndrome knowledge forward. But there are some recent success stories, such as the POA2R in membranous nephropathy and the APOL1 in chronic kidney disease. You can help move research forward as a patient by participating in research studies, making a data donation to the network, and asking more questions, and being a more active person in this community. And really, the NephCure Kidney Network is a patient registry that collects your information in a scientific way to really help to push all this forward. So at the end of the day, if it can be overwhelming to sort of wade into all the things that go into research. But at the end of the day, what you can do as somebody who is a patient or an advocate for a patient is to help band people together and get more information and awareness out there, both patients and physicians, about these diseases that are going on. And the NephCure Kidney Network is the primary way that you can do that. So I'll turn it over to Chelsea to talk about the next steps that you can take, and then we'll take some questions.
Great, thanks. Again, I just want to highlight our next steps. If you visit our website, nephcure.org, research, participate in research, we have a lovely map so you can find research opportunities near you, and it just lists all the research opportunities that are out there available to nephrotic syndrome patients in general to see what you're interested in. One of the first things that you could do it tonight if you really wanted to, is you could make a data donation at the NephCure Kidney Network. And again, that website is nephcurekidneynetwork.org, and it's listed right there. We talked a little bit about the NephCure Accelerating Cures Institute, so keep an eye out. We're going to be releasing a lot more information on that soon, and it'll really show you how you can help push that effort forward as well. And again, I think one of the most important things that you can do is ask questions, ask your doctor. Really just be your own advocate, like Dr. Hogan said. Advocate for yourself, and don't be shy. Don't be afraid to ask questions. It's okay, and it's great. And at this point, I don't have any questions that were typed to me, so I'm going to go ahead. I'm going to unmute everybody, which will take me a minute. And then I think at this point, we can just open the discussion. If anybody has questions, just go ahead and you can give a little introduction if you would like, or you can just go right ahead and ask your question. So at this point, the floor is yours. Are there any questions? Anything that we can address for you right now?
Yes. Is there any research on post-transplant recurrence of FSGS and any new treatments for it?
That's a very good question, and one that comes up time and time again at patient seminars. It's a very difficult condition, and there are a few new agents which are being considered, although not in a way that is bringing together a lot of transplant centers and nothing in randomized fashion. But again, I think that it comes down to the barriers to that happening in the past, or the things that I mentioned about people being in silos or being in their own institution. And although there is literature about treating post-transplant focal sclerosis, it's almost always out of a single center, meaning one center has an experience, and we need to move that forward. Things like CureGN and Neptune are trying to address this issue, but not in the transplant population. But given enough numbers through networking, it's only a matter of time before that moves forward into the transplant setting. But unfortunately, there is nothing randomized or nothing on clinicaltrials.gov that indicates any trials. Although at various academic centers, they may be trying different agents, and so it just takes asking your doctor about who that doctor is in touch with at other centers if nothing is currently available at yours.
Good, thanks. That was a really good question. I liked hearing that answer. That was helpful for me as well. I did get a question typed in about observational studies, and since you touched a little bit about Neptune and CureGN, can you talk a little bit about why these observational studies are so important and who's eligible for them?
Sure. So I'll focus on the two studies that are going on currently. So the Neptune study enrolls patients at the time of biopsy. So at the first time that a patient presents with the nephrotic syndrome, in children you do not need to have a biopsy, but in adults who are going to have a biopsy, we try to enroll patients at that time when they first present with the disease. And then we enroll patients and we follow them over time, and at various intervals we collect new data. How are they doing? What are their labs doing? And we collect blood and urine samples, and we bank those in a research bank, essentially, so that if questions come up and research is to be done in the future, we have all of this information from the very beginning. And really, those are seeking to enroll patients with minimal change disease, focal sclerosis or FSGS, and membranous nephropathy. And I can answer more questions about that so far, but basically there's between 450 and 500 patients that have already been enrolled in that. Now, the CureGN study is a different type of study. This is trying to enroll patients with focal sclerosis, minimal change disease, membranous nephropathy, and IgA nephropathy, and follow them over time, over about 5 to 10 years, again, collecting the same type of information. But these patients can already have the diagnosis. As long as they've been diagnosed within the last 5 years, they can join one of these studies. And this is seeking to enroll 600 patients with each disease, so 2,400 patients across the country. And both of these studies are involving dozens of sites throughout the country. This is all available online. You can find your local participating your local participating center. But if you think about the power of having, samples and data on 2,400 patients, and if somebody comes along with a question about a molecule that's important in focal sclerosis or FSGS, that could even impact on the understanding of recurrent FSGS, because if a molecule is discovered in, a certain proportion of your patients with FSGS before transplant, then that molecule may be the problem in the patients that recur after transplant. So this is probably the most important study ever done in nephrotic syndrome. And so if you go to curegn.org, you can see all the different sites that are going on, and you don't even need to be referred by your provider. You can contact coordinators directly and figure out if you can participate in these studies. I hope that answered the question. If not, I'm happy to answer up any follow-up questions about that.
I think that was very thorough. Again, I'm learning a lot just from hearing these questions and answers. Does anyone else have a question? I do have some more typed in, but I want to open the opportunity for anybody to verbally ask. Okay, so I do have one typed in about what about pediatric patients? Seems a little scary. What studies are there for pediatric patients?
Yeah, so I agree, and I treat adults, but I do have children, and I agree. It's a totally different ballgame with children. In some senses, children are the more ideal patients to study with things like nephrotic syndrome or to think about, and the reason is because they do not have other conditions that may make it difficult to interpret certain aspects of their care. For example, as adults age, we have other chronic conditions. We have high blood pressure, we have high cholesterol, and other things that can come in, diabetes, that can make it difficult to figure out, well, what's causing it. But in children, it's a much more pure patient population. So, but it doesn't mean that it's not scary. And I think that what I'd like to, so both NephCure and CureGN are both enrolling for pediatric patients. And these guidelines and what they do for the pediatric patients have been drawn up by pediatric experts. So instead of drawing a lot of blood, there's a very, very little blood drawn to patients, and it's always coordinated with a clinical visit. So it's really done in order to try to minimize any, negative effect on the child. And sometimes in these studies, you don't even need to have a biopsy. So if a patient has nephrotic syndrome, understanding that not all children get biopsies, that those patients can still enroll. And so I think that just asking your pediatric nephrologist, your pediatric kidney doctor, what's going on locally, and even going to NephCure and CureGN in those websites, trying to figure out who is participating near you. And the other thing is that there are studies that are going on specifically in younger patients, and one of them was listed on the slide earlier, where we're studying patients with FSGS and treating them with vitamin D. And so if you're worried about experimental drugs, there are some other sort of supplemental drugs like vitamin D, which are also available, which may be not as scary to think about or have conversations about with your doctor. So I think just keeping the conversation open, asking very blatantly about your concerns so that they can be addressed, and keeping active in terms of networking, registry, and through the internet to figure out what's close to you will help you to keep informed so you can decide what's in the best interest of your child.
Great. That was a really thorough answer as well. Do we have any other questions? If you want to type them in or shout them out.
I have a follow-up question, a little bit of a follow-up question to the one I posed earlier. If there were to be a stem cell kidney, transplantable kidney, is there any sense of whether the FSGS could or would recur in a stem cell replacement?
So if I understand your question correctly, is that if somebody underwent a stem cell transplant, either with or without a kidney transplant?
Well, no. Now, my question, I know that there are some prototypes of stem cell generated kidneys being developed.
Okay.
And, I was thinking that, that would be great, except I'm thinking because of my understanding of FSGS that it's an antibody, and the antibody could attack the stem cell kidney just as easily.
So the challenge in FSGS is that we really do not understand it at all in terms of why it's recurring in the transplant. And you can reference this with what your doctor said or what you've read, but we have not. Although the theory is that there is something circulating in the body that causes the protein in the urine and attacks the kidney. And some people think that it may be an antibody or some other thing produced by the immune system, that there is no evidence that has conclusively shown that to identify what that molecule is. And so it's hard to make if you don't know what's causing the problem and you don't really know what the target of the problem is in the kidney, then I don't think anybody can really say if one had a stem cell generated kidney, if that kidney would have that target. I hope that makes sense. But basically, we're taking two things that we don't know and then putting them on top of a third thing that we don't know. And so although these are ideas that are coming out and it's not the wrong way to go, it doesn't mean that just because we don't know this information that we shouldn't be thinking outside the box. But I don't think anybody can really even, unless we do it in animal models first, really even make an educated guess as to what would happen in a human. Did that answer your question?
I think so.
I think it raises the point even further that of how essential research is and how important it is to, tell people and talk to your doctor about what you want and advocate for yourself and for what you want to see in the research world from all angles. I do have another typed in question. What if...
Can I just make one comment?
Sure, go ahead.
So I think that this is a good example of something that, this comes up constantly, that recurrent FSGS is such a difficult thing to understand, and the implications of having it are so large. But if you had a network where instead of having 10 or 15 patients from one center, where you had 100 or 200 patients who are coming together to share data, then that's patient power to force the community to take notice and to move things forward for you. And I think that's, again, without that, it's very difficult to move things forward with very rare diseases. So, sorry, I just wanted to make that comment.
No, that's a really good point. I'm glad that you brought that up. So I did have a typed in question. What if my doctor says I shouldn't participate in the trial I asked about?
Yeah, so sometimes it comes down to inclusion and exclusion criteria, as I mentioned before, where a certain patient may not fit what is required to enter into the trial. And sometimes doctors are looking out for the best interest of the patient, where a given therapy may not just be the best for them. And sometimes doctors, particularly if they're not running the trial or involved in the trial, are just not in the know about what's going on in that particular trial. And so I think that either having an open dialogue with your doctor about why you're not a good fit for that trial is important. And if you ever feel like you're not comfortable talking to your doctor and asking those sorts of questions, then we need to figure out other resources for you to find to answer those questions. That may mean seeking a second opinion, or again, things like the NephCure Kidney Network and banding together and using social media and other ways that you can get your answers. But the first question would be why wouldn't your doctor think that you're a good fit for that trial? It may be as simple that you do not meet the criteria. But if you're ever worried and you ever see something about a trial, you can always contact the coordinator directly after finding the information on the website, and you can be evaluated to see if you're a good fit for that trial at the enrolling center or a different center. I always say do not take no for an answer, in the sense that you have to have your questions answered. You have to be satisfied with the answers that you get. It doesn't mean that you're going to always achieve your goal, but if you don't push forward and you don't ask questions, then you'll never know if it's just that you were not matched up with the right person or that there was just a miscommunication.
Hi, I have a quick question.
Sure.
Go for it.
Just wanted to know, do you know of any trials that are based on diet, like gluten-free and that whole arena, dealing with the diet or allergies that could affect the nephrotic syndrome?
There are no diet-associated trials that I'm aware of that are NIH-funded and that are on clinicaltrials.gov. This is constantly updated. So there's a website called Clinical Trials. It's just the way that's clinical, clinical CLINICAL trials, translationalresearch.gov. And you can always find all of the trials that are registered with the government that are sanctioned to be enrolling for patients. And if you put things in like kidney disease or diet or gluten, you can search for keywords, and that'll give you the most updated, and it'll tell you what sites are recruiting and who you can contact. There are no studies, as far as I'm aware, that are exploring gluten or diet effect on nephrotic syndrome. There is the exploration of vitamin D, which is thought to be involved in the kidney cells and protein in the urine. But as far as I'm aware, there is not anything on diet. However, the observational studies that are being done are collecting a lot of information on diet. And again, you know, if you have 600 patients with a given condition, you start to notice a trend, then you start to generate a question that can be tested in what we call a prospective fashion, where we try to recruit patients to do that. And so we see those signals through things like PureGN or Neptune or the NephCure kidney network, and you start to see this trend of diet-associated changes, then that would be a reason to push for a trial for those interventions.
Do we have any other questions?
I don't know. Can you hear me?
Yes, we can hear you.
I don't know if this is a question or, so I'm a parent of a daughter, minimal change, biopsied 5 years ago. And as we learn of her diagnosis, a research project in Europe from the 1970s, and I just feel 5 years has gone by, frequent relapser. And we're continually being told protocol, protocol, protocol. I mean, at this point, is that all there is for minimal change? Is that study in the 1970s? Or if you're living in an area and they're following that protocol, I guess what should we do? I mean, we have the best case scenario. I understand that with minimal change and receptive to steroids, but with frequent relapsers, sometimes I just feel like protocol stinks and I don't know what to do.
Yeah, this is, you're right. You sort of, with minimal change disease, well, it's okay because it is responsive to steroids in some cases, but it's awful. It's also awful because you're waiting for the shoe to drop again when you're in remission, and you're just constantly on medicines and coming off medicine. So the protocols are developed to help to guide therapy, and there's really not. These are based on, some of them are older studies and some of them are newer studies. There is some new data about using, agents, which I imagine that you're a doctor, that you've heard about things like rituximab and other agents. And again, I'm not advocating, but these are sort of new data that have been coming out in the last 5 years or so that sort of gets away from the older protocols. But minimal change is a really tough condition in a sense that, as the name suggests, we really just do not understand it at all. It's in the same group as FSGS, where we've really not made much progress, as you've mentioned, from the 1970s and even the 1940s and 50s when this was first recognized, where back then it was called minimal change and they gave steroids, and in 2015 we're doing the same thing. So I think that, sort of going back to your question, our protocol, is there anything beyond protocols? Well, the protocols are developed, but they should be individualized to the patient. And obviously having frank discussions with the doctor about, well, is this the right regimen for my child? Is there anything that can be modified from the protocol in order to help minimize side effects? And then again, thinking about other new agents that are being used off-label to try to keep a longer remission or keep things, in remission, as long as possible. So I don't have a good answer for you on that. And again, one of the common themes that always comes up is that, and this is even with my patients, because I see almost exclusively patients with these types of diseases, and it's a very frustrating conversation for all parties. And at the end of the day, again, this is why we're here tonight, is to say that, if I'm not giving you the answers that we want to hear, it means that we should be frustrated, but we should use that as a motivation to try to push the research forward so that we're not having the same conversation about minimal change disease in 10 years. That minimal change disease is called something else. Membranous nephropathy, as I mentioned, this PLA2R antibody discovery is enormous. I cannot understate how important that is to make that type of discovery in our field. No longer will it be called membranous nephropathy in the future. It'll be called this PLA2R nephropathy in patients who have it, and that speaks to the mechanism, and people are trying to develop specific treatments. So this is what we need to do for these other conditions as well.
Is there some known number of iterations of FSGS?
I could speak all night about this, but FSGS is all of these diseases that we're describing, and this is, again, some people, I don't want to assume knowledge, but I also don't want to talk down to people. But basically, when we talk about things like FSGS, membranous nephropathy, and minimal change, if you can hear the way I'm describing them, these are descriptions of the way that the kidney looks under a microscope. Right? This is not telling you about what is the actual cause of that, the way the tissue looks under the microscope. So there are many different types of FSGS categorizations. They've classified it based on the way that it looks, and then try to associate that with various, either the way that the patient presents or acts or responds to therapy. And then there's other types of FSGS that seem to be associated with abnormalities in the urinary tract, abnormalities in the anatomy of the patient, or diabetes or hypertension. So, but I think that these boxes that we put things in are a bit nebulous, because I'm hoping that based on these trials that we have going on now, that we're just going to all be proven wrong. That for patients with recurrent FSGS, that they're going to be called the FSGS equivalent of PLA2R, that this is the molecule, this is what's causing the disease. And so all of the things that we're putting into boxes now are going to be proven wrong because we do not understand them. So I could talk about the different categories of FSGS based on the way it looks under the biopsy, or any review paper or any website is going to break it down into what's called primary and secondary and genetic. So once we really understand these, and these trials are going to help us to understand these eventually, that will all go away, because we will understand the mechanism of the disease in some proportion of patients with these diseases. So that's why I'm hoping, again, that in 10 years, I'm not just saying you have minimal change and you're just like the rest of the minimal changers, and you're an FSGS and you're just like everybody else with FSGS, but that you have this mechanism, and I'm thinking about how we can go beyond protocols and really tailor our research and our therapies towards helping you, and not just put you in this generic category. As you can imagine, as you look at all the diseases, the same treatments are used across the board. And that usually means that we don't understand it if we're using the same treatment in the 5 different diseases that we're talking about.
So we are about at the hour mark for this. I want to thank everybody for being here tonight, and I want to give a huge thank you to Dr. Hogan for the wonderful presentation. I hope everybody learned something new tonight and that you feel a little more empowered, a little more motivated. And if you have any follow-up questions, do not hesitate to reach out to me. I will do my best to answer them or forward them to Dr. Hogan to get you an answer in a timely fashion. And with that, thank you everybody again for being here, and I hope you all have a good night. So again, please stay in touch if you have any follow-up questions.
Thank you.
Thank you.
Thank you
Have a nice
very
night.
much.
Okay, so it's just staff left, or
Who else is on?
Dr. Hogan is still on. Hold on, let me turn the recording off.